First of all, I want to thank all of you for inviting me over to speak here. It was really an honor to me, and I have to admit I was quite nervous about it, because here I'm standing in front of you as parents of children with CDG, which are actually the real professionals concerning this subject. So what are we going to do today? Let's see that this works. Today I will walk with you through the different or some of the different eye abnormalities that we can encounter in patients with CDG. But before we are going to discuss all these different topics, we first, of course, want to know and understand how vision works. And actually, that is quite simple, because looking at an object is somewhat similar to taking a picture of an object with your photo camera. So the first thing we want to do is to point our camera towards the object. And to do so, the muscles surrounding the eye, that are these ones, need to work together in an extremely coordinated way to look at an object. For example, when we want to look to the right, only the muscles that are located at the right side of the eye need to contract, while all the other ones need to relax and sit back. Of course, this difficult job will be coordinated by our big boss, the brain. Next, we want to take a picture with our camera. And before doing so, we are going to take a closer look to this camera. And actually, it's a quite sophisticated one, if we may say so, because in the front of our camera, we have an excellent lens that can be adjusted with the little muscles that are on top or at the bottom of the lens, so that we also can look at objects that are located really close to us or are located really far away. At the back of the eye, we have the film of our camera, also called the retina, and all the objects we are looking at are projected onto this retina. Now, information is registered onto the retina by specialized cells called photoreceptors that are located on top here. And these photoreceptors act as little antennas that pick up all the information that is coming from the object. And mainly we have two different antennas, namely the rods and the cones. And both of these photoreceptors have different functions, meaning, for example, that the rods are really good at taking all the light from the environment. So actually, the only thing that the rods can do is say, okay, I see something or I see nothing. So what they observe is a black and white impression of the object in front of us. On the other hand, the cones, which are these triangular-looking cells, can observe also the different colors. So all the information that is gathered by the photoreceptors will be transferred through these little electric fibers to the optic nerve. And the optic nerve is actually nothing else than a big USB cable that is connecting the eye with the brain. Another interesting feature of the retina is that the rods and the cones are not evenly distributed onto the retina. And when we look at this graph, we see that going from the periphery of the retina towards the center of the retina, so like in the eye from the periphery to the center of the retina, we have at the end most of it the rods, while in the center more cones are localized that give us an excellent detailed vision with colors of the object we are looking at. Now, at the last part, all the information gathered by the eyes will be sent by the optic nerves to our big USB cables to the back of the brain, where all the information will be further processed. And since we get information from two eyes instead of one, we gain a perception of depth by it. So now we know, at least for the part that you can hear from me, everything about vision. and it's time for our first topic then. Strabismus is a frequently occurring problem in patients with CDG, and it's defined by an abnormal ocular alignment. Normally, when we look to an object, both eyes are pointed into the same direction. In case of in a patient with strabismus, this is not the case, and like you can see in this picture, the affected eye can deviate in any direction. In most cases, strabismus is caused by a bad communication between the eyes and the brain, while the primary problem can be located in the eye, the brain, or the communication itself. Strabismus can occur intermittently or can be constantly present. When strabismus occurs only now and then, patients can have periods where they have double vision, like they see instead of one hand, two hands at the same time. Now, when we look on the long term, strabismus can also cause a lazy eye that is also called amblyopia. Normally, when we are looking at this apple, a nice picture of the apple will be projected on the retina of each eye. The brain will then fuse both images to what we observe as an apple. Now, this does not allow us only to see the apple in a nice and clear image, but also to estimate how far the apple is lying away from us. In case of strabismus, both eyes look at a different angle towards the apple. So there is no similar image that the brain can fuse. And the patient will again have periods of double vision. Now, the brain gets really sick of it when it gets a lot of times where there is double vision. And it's going to decide on the long term to suppress all the information that it's getting from the diseased eye, leading to the fact that we are only observing then our apple with one eye because this eye becomes functionally blind. Again, this will lose because only information from one eye. This will lead to loss of depth perception, so we cannot decide anymore if the apple is lying really far from us or just a little further away. Since when the eye turns functionally blind, there is not really a cure anymore to get vision back in the eye. So early treatment is always recommended in patients with strabismus. And one of the early managements is the use of patch therapy, and that means that for several hours a day we are going to put a patch that is covering the healthy eye. In this way, we are going to stimulate the diseased eye to work a little bit harder so that the communication between our brain and the eye will be further optimized. Our next topic that we are going to discuss is called nystagmus. And nystagmus is actually just a fancy word to say that there are rapid eye movements that we cannot control. And here we have a slow motion picture of it. I hope it works. Yeah. Again, nystagmus is the consequence of the fact that there is a bad communication going on. And this communication can go wrong between the eye, the brain, but also the balance system that is located into the inner ear of the patient. Now, you can imagine when your eyes are moving like this all the time that you cannot really look good at an object and that you are experiencing blurred vision, or the patient can also have the impression that the environment is moving around him. Now, in some cases of nystagmus, the symptoms are less present when we are looking in a certain direction. Now, what are these patients then going to do? They are going to keep their head like this, because like this they have a world that is standing still in front of them, while they are looking like that, everything is moving. So you can also have patients that assume a strange head position. in case of treatment, not all treatments that are available are always really effective. So normally we are only going to treat patients that have really important symptoms, and then you have different options, or we can use glasses to diminish nystagmus, or we can use drugs that influence the activity of your extraocular muscles, or we can even ask a surgeon to fix the extraocular muscles in a certain position so that we have less symptoms. Another frequent eye abnormality that we see occurring in children with CDG is, of course, retinitis pigmentosa. And it's defined by a progressive degeneration of the retina. And this degeneration is caused by the deposition of pigments onto the retina, causing a loss of photoreceptors. And like you can see on this picture, if the light is there, you see that the degeneration starts at the periphery of the retina, going to the center of it. So patients that will suffer from retinitis pigmentosa, their visual field will close like a curtain, like you can see over here. And the visual field means the angle that you're able to look in. And for me, it's like that. Everything that is behind here, I cannot see anymore. Also, I'm trying really hard. So what is happening, it's closing like a curtain, like that. So you see that initially in the disease, we will mostly lose the rods of our photoreceptors, while the cones that give us color and detailed vision that are lying at the fovea, the center of our retina, are preserved until the later stages of the disease, so that most of the patients only notice that there is a problem when they are already in a longer way of their disease. Now, since we first lose our rods that are really capable of catching all the light from the environment, one of the first symptoms of patients with retinitis pigmentosa is night blindness. And I don't know if you can see it right, but normally this picture here, you still can distinguish that there is a house standing over there, while here, yeah, you cannot see the house anymore. But I think that from the seats over there, you don't see anything at all for now. So the other effect will be that because our visual field is closing like a curtain, that tunnel vision is going to appear. And this means that the patient looks to the world like it was looking through a tube that is getting smaller and smaller and smaller. So if a patient with retinitis pigmentosa that has been already working for some years would look at this picture, it would only see the really point he is focusing on, like this. Now, for a parent, why is it important to understand that there can be night blindness, that there can be tunnel vision? Both of these symptoms can cause a patient to be really anxious because, yeah, when it's dark and you don't see anything anymore, or when you have a tunnel vision and everything that is happening over there you are not aware of anymore, you can become really frightened. For treatment, no real curative treatment is known to date. We heard from a mother over there that her child got already high doses of vitamin A. That is something that has been tried, but do we have a better success rate with it? We don't know at the moment. The next topic is something that we see a lot in patients with CDG, but that we also see in a lot of people in a normal population, like, for example, also me, which is nearsightedness. Normally, when we look at our apple, a nice and sharp image is projected onto the fovea, the center of our retina. Now, when we are looking to a patient with nearsightedness, the eyeball is actually somewhat too long, so that the picture of the
apple is not projected onto the retina, but at a point in front of the retina, and only a blurred little picture will be perceived by us. So another feature of it is that, maybe we're going to go back to the slide before, that if we are going to move the apple further away from us, that the focusing point is also going to further away from the retina, and that the image of the apple is becoming more blurry when we move the apple further away. Now, when you are going, on the other hand, move the apple closer to the eye, then you're going to see that the focusing point is also going to be closer until it hits again the retina, and we get a clear and fine apple again. And for me, it would be when I take my glasses off that this projector needs to be like here before I can see it nice and clearly. All the people with the glasses can try it for themselves. So if we summarize what I've been telling there with the strange eyes in front, when an object like our apple is nearby, we see it nice and clearly, but when the apple is going further away, it becomes blurry, and here at the end, if we don't know we are looking at an apple, yeah, I wouldn't tell this is an apple anymore. The treatment you already know, that is wearing glasses. And what are the glasses going to do? They are going to make that the focusing point that was now lying here in front of the retina is going to be projected again nicely on the retina, so that we see a good, sharp and detailed picture of our apple. Our next topic that we are going to discuss is cataract. This does not occur too frequently in patients with CDG, but has been described, for example, in patients with Alg8 deficiency. And it's defined by a clouding of the lens. I don't know if you see it in my eye here very well, but there are little clouds inside. And in this patient, you also see that there is something strange going on with that eye. Now, I think it's easy to understand that if the lens of your camera is filthy, that you cannot take any nice pictures with it anymore. The other consequence is that the light that has to pass through the lens has difficulty to get through it and will be reflected for part of it. So patients will complain in the beginning of their disease of glares when they are looking to bright lights. On the other hand, since our lens of the camera is filthy, we will also have this blurry vision of the environment around us, and this problem can already occur in the beginning of the disease. Treatment is actually quite easy. We take out the diseased lens and replace it by a plastic one. The next topic is again something that occurs mainly in certain types of CDG, and it's called coloboma. It means that there is a structural defect in any part of the eye. So here you see an example from a structural defect that is present in the iris of the eye, which is the colored part of the eyeball. And yeah, that is easy to recognize as a parent, but it can also be that this structural defect is present in the retina that was lying at the back of our eye, or to the optic nerve, which was even further away to see. So all these defects can only be viewed when someone, an ophthalmologist, is looking with his special instruments into the eye. For functional implications, yeah, when there is a little part missing in the eye, yeah, it doesn't bother your vision, so yeah, it looks strange, but nothing else. However, when there is a structural defect within the retina or within the optic nerve, you can have a certain amount of vision loss of it. The last topic we are going to discuss then is optic nerve hypoplasia. Again, something that is not so common in patients with CDG, but that we see occurring. And it means that the optic nerve, so our big USB cable from before, is not well developed or can be absent in total. So this will lead that there is a really bad communication going on between then the brain and the eye that is lying at both ends of the nerve. So patients will, of course, have vision problems, but also because there is that bad communication going on, there can be strabismus or nystagmus. Again, no treatment is possible, or no curative treatment is possible to date. With this being my last slide, I want to thank you for listening to me, and sorry again for the hearing device problems. And of course, I also want to acknowledge all the people that I've been working with in the lab for the last 2 years.